Good evening, everybody. Thank you very much for signing on tonight. So we're going to go right to, we're going to get ready to go to some call-in questions from home, but I'm going to start off with a couple of questions that I've received during the week just in preparation for that. So I just want to talk about a couple of things just to clarify a few things from last week's lecture. I got a lot of emails from people with interstitial pulmonary fibrosis, IPF, saying that this webinar was not for us, it was for people with COPD. As I mentioned in my email, I kind of have to disagree with that because, even though some of these inhalers are not part and parcel in the treatment program and don't show clinically proven improvement in lung function with people with IPF, we have actually seen a lot of patients with IPF who take many of these medications and have gotten subjective improvements. And so when we talk about the difference between subjective data and objective data, so the difference between subjective and objective, so when something is objectively and objectively significant, it means that we can measure numbers or we can see objective facts that tell us it definitely works. Now, sometimes we may not see an improvement or a change in lung function, but the person feels better, the patient feels better, and this happens even with people with interstitial pulmonary fibrosis. So the simple fact is, if you're going to take something like albuterol, maybe as not necessarily, I won't use it as a rescue inhaler, but we have some patients with IPF who nebulize before their exercise sessions, and so if you don't see an objective change in the pulmonary function, in other words, if the research says that bronchodilators won't necessarily help somebody with IPF. However, taking it 15 minutes before your workout allows you to do a bigger workout, and we can take that objective data, or the person feels less short of breath during the workout and therefore can do more, then it is unquestionably of benefit. And there are certain things, there's a whole push in medicine today to say evidence-based research, and I'm going to be, perfectly honest when I say there are some things that work and we don't quite have the empirical evidence to say why, or we don't know exactly why. And so, I talk about the fact that we consider ourselves here Malcolm X physical therapists or Malcolm X rehab by any means necessary, because we say whatever is going to work, we don't care. We'll turn over every stone to figure out what's going to help you the most. So that's one thing. Also for the IPF people, something that's really hot on the market that people are talking about now is pirfenidone, which is a drug that people have been using in Europe. It has been shown as an anti-fibrotic agent and an anti-inflammatory agent. The company has had a hard time getting it on the market in the US, but there's a huge political push to really speed up the process, because as you know, IPF is no joke, it's serious, and so the longer it takes, the more people are really going to be in trouble. So if you are somebody with IPF, it's worth your while to get active with the different organizations and to try to make a political push to get some type of quick approval for pirfenidone. So I'm going to go to one of the questions that I got during the week. And the first question is from Audrey, and the question is about medications, and it says, can Combivent inhaler be used instead of albuterol? I'm also taking Spiriva and Symbicort. Combivent used to work for me before I started on Spiriva. ProAir doesn't seem to work as well for me. So just not sure if these three can be used together. So if you have the chart that I gave you last week, okay, and I have something dawned on me this week that I think is going to make this a lot easier to understand. But if you recall, okay, let's talk about the different medications here. So we talked about the basics, and we talked about the first delineation amongst pulmonary medications being between bronchodilators and anti-inflammatories. Anti-inflammatories are also steroids, and I'm going to give you something else tonight. We're going to just firm that up a little and call them corticosteroids, because that's going to help people understand them a little bit better in my new system. So Combivent is a combination of two medications. So Combivent is a combination of two classes of bronchodilators, because bronchodilators are then further broken up into beta-2 agonists and anticholinergics. So let's go back to this list, because I'll tell you, for years I've been trying to think of what is the best way to get people to understand their pulmonary medications. And it's very difficult. And the reason is because we have things like, breaking it down by class, anticholinergic, beta-2 agonist, anti-inflammatory. We have generic names. We have trade names. And then, we have multiple different names for each medication. But it suddenly dawned on me this week, and it's kind of amazing. I'm shocked at how easy it really is. And we can break this down into ABC. Okay, so again, we talked about bronchodilators and anti-inflammatories, but now I'm going to go strictly by class only. Because if you remember, I talked about the fact that, like in the 70s or 80s, if you went to a Chinese restaurant, you'd say one from column A, one from column B, one from column C. Let's break it down into ABC, where A is anticholinergic, which is a bronchodilator. B is beta-2 agonist, which is also a bronchodilator. And then C is for corticosteroids. So again, the majority of people are going to have one drug from each class. And we talked about the fact that many of these drugs are combination drugs, and we'll talk about that. So again, just label this BAC, and I'm going to put out a new chart that I'll get to you sometime later this week or next week, and it's going to say ABC for anticholinergic, beta-2 agonist, and corticosteroid. So back to the question. So can Combivent inhaler be used instead of albuterol? So Combivent is actually a combination of two medications. It's a combination of albuterol and Atrovent. So the thing is, if you're saying that Combivent works for you better than albuterol, that makes perfect sense, because Combivent is albuterol plus a second class of bronchodilator, which is Atrovent or ipratropium bromide. Okay, it's the same thing as Duoneb. So the answer is, can Combivent inhaler be used instead of albuterol? My answer to everything is always going to be ask your doctor. Okay, as I mentioned to you, I am relaying to you my experience over the past 22 years in observing my patients. I'm not giving you specific advice, and please don't say Noah told me to do this. Please ask your doctor. But here's the thing. So if you are taking, on its face, both Combivent and albuterol are rescue medications. Okay, Combivent is a combination of albuterol plus another medication. I'm also taking Spiriva and Symbicort. So now let's break that down even further. Spiriva is an anticholinergic. Combivent contains Atrovent, which is an anticholinergic. So Atrovent is the short-acting version, Spiriva is the long-acting version. The companies behind Spiriva and Atrovent say that the medications should not be taken, you should not be taking both medications. However, I have seen a number of patients who do take Spiriva and also take Atrovent or Combivent or Duoneb or ipratropium bromide. So the answer is it possible? Absolutely, it's possible to take both, but ask your doctor, because there may be reasons why he or she does not want you to take both, or there may be reasons why he or she may want you to take both. Another thing, Combivent used to work for me before I started on Spiriva. ProAir doesn't seem to work as well, and ProAir is also albuterol. Okay, and then just remember that Symbicort is a combination of a long-acting beta-2 agonist, and albuterol, which is also in Combivent, is a short-acting version of a beta-2 agonist. So you don't want to be stacking these things one on top of another, because these are going to compound the effects. But again, these are questions asked specifically to your doctor, but the answer is it is possible. Okay, Nicole, do we have a question from home?
Yes, Noah, we have a question from Becky about COPD and low SATs. Becky, would you like to ask your question?
Becky? Becky, are you with us?
We can hear you. Or we can hear you.
What's that?
Becky, I think we can hear you. Do you want to ask your question? You can just talk it out loud to your computer, and the microphone might be on.
Okay, I can hear you now, Becky. Becky is in the building. Sure. When you're sitting, how much oxygen are you wearing, or are you not wearing oxygen? And how much oxygen do you wear? How many liters? Okay. Okay. And have you checked your oxygen saturation when you're out? And what is it usually? Okay. So that's a very common question, okay, and this is a very good question. So here's the thing, and there's a couple of different things to talk about here. So we've spoken a number of times about, oxygen saturation and what is the ideal oxygen saturation. So under normal circumstances, we want people at least in the mid to high 90s. So 92, 93, is it okay? Probably, okay, but remember, if you recall, when we spoke about oxygen saturation, I told you that specifically 90% is a very crucial number. And the reason why 90% is such a crucial number is because the way that the body gives up oxygen, it is not linear, okay? So if it were linear, what that would mean is it would look like this, and it would be very predictable, and we'd know that, okay, if we go 5 steps, it comes down here, if we go 10 steps, it comes down here, and so on and so forth. But the way that oxygen, the body gives up oxygen and utilizes oxygen is that in general, okay, when we talk about percentages, this is called a sigmoidal curve, meaning it's S-shaped, okay? So you notice that between 90 and 100% oxygen saturation, this line is pretty flat, okay? Meaning that you're walking close to the cliff, you're still not over the cliff, you're not over the cliff, you're not over the cliff. This is all pretty much the same, but once you drop below 90%, okay, that is where your body really starts, the partial pressures of oxygen really seem to really begin to diminish at a much more significant pace. And so that's why people sometimes get confused and they don't realize that, what's the difference between 91 and 90 and 89? But there's a much greater difference, believe it or not, between a true reading of 91% and 89% than there is between a true reading of 91% and 99%. So it's much more significant once you drop below 90%. The other thing to keep in mind here is that most pulse oximeters have a plus or minus of 3%. So for example, you say that you are sitting at rest and you're at 92%, okay, on 3 liters. But if we take that plus or minus 3%, and this goes for anyone using a pulse oximeter, okay, that 92, in fact, based on the error rate of the pulse oximeter, can be either 95%, which would be great if we knew it, or it could be 89%, which again puts you over the cliff. So my suggestion would be to shoot for an oxygen saturation somewhere between 94 and 96%. Is there going to be long-term damage, by going below 90%? I'm not going to say yes, and I'm not going to say no. I'm going to say, is it possible? Okay, it is possible, but it's not a definite. So you have to think that every time you go below 90%, your body is going to start to send out signals like something's wrong here. So for the average person, could you tolerate a few minutes at 87%? Yeah, probably. But if you have any, conflicting or comorbidities, things like heart disease, things like coronary ischemia, things like arrhythmia, all these things can create a cascade that can cause complications. So for me, I'm always going to err on the side of being oversaturated rather than undersaturated. And my guess is that if 3 liters is keeping you at 92 to 93% at rest, then 4 liters is probably not significant to keep you well saturated during activity. So my suggestion would be, when you're walking room to room, and these are the times that you say you're desaturating to 87%, I would say turn the oxygen up. And I would say when you're going out, and I know that gets tricky because we're all on a limited oxygen supply, but I would want you to have as much oxygen as possible. So I would even recommend 5 or 6 liters. I assume you're using a nasal cannula. One way to increase the saturation would be to use a mask. It's not something that could be used with every oxygen system, but these are some ways that we could really try to make this work. Is there a second question there? Did we?
I think we've answered the second question. It was from Kathy. It was, can saturation ever be improved with exercise?
Okay, so let's go with that, because that's actually a different question slightly. Okay, so can oxygen saturation be improved with exercise? Most people will say no. I say maybe. And what do I mean by that? So when we talk about oxygen saturation, if we want to talk about the big three, what are the things that impact oxygen saturation? And I'll also, bring this into the context of how good is your body at using oxygen. Another way we can refer to this is aerobic capacity. So aerobic capacity is really how much is your body able to do and how well is it able to use oxygen. And it's really based on three main things. So it's based on, number one, how good are your lungs at moving air in and out? Number two, how good is your heart at pumping blood? And number three, how good are your muscles at using oxygen? And what I mean by that, okay, is that any change in these, for better or for worse, can impact how your body uses oxygen. And for people with pulmonary disease, what we see very often is we'll see definitely a difficulty moving air in and out. Okay, sometimes we see, there are a lot of people who have heart disease and lung disease, and so there we might have a decrease in the ability of the heart at pumping blood. And then how well conditioned your muscles are, this has to do with cellular chemistry, and the more conditioned you are, the better your muscles are going to use oxygen. So again, if we go back to the car example, a car has many different parts. So if we think about aerobic capacity, or how your body uses oxygen at the efficiency of a car and how many miles per gallon you get, any change for the positive in the car, not a paint job, but any change for the positive, meaning you clean your oil filter, you change your spark plugs, you have the right amount of air in your tires, you use a better gasoline, you have a better motor. All these things are going to make the car more efficient. So if your car doesn't have enough air in the tires, it's not going to be as efficient at using gas. So any change in any of those big three, meaning if your lungs have a more difficult time at using at moving air in and out, if your heart gets weaker, if your muscles get weaker and become less efficient, that's all going to negatively impact the way that your body uses oxygen. However, if we get you exercising and we can, improve your lung function again, which a lot of people believe you can't, I believe we probably can. And no, I take that back. I know we can. Not in all people, but I know we can improve lung function with exercise. And we can improve the strength of your heart, and we can improve the efficiency with which your muscles use oxygen. Any change in any one of those areas is going to improve the way that your body uses oxygen saturation. Do we have another question? Okay, so I'm going to go to a couple of other questions that I got during the week. So these are, and please, if you have questions, by all means, please let us know. I'm happy to answer them. So here are some questions that I got by email. This is from Jan. When I take my Spiriva and my Q-bar, initially I become short of breath. Is this common? Okay. Is it common? Yes. Is it a direct result of the Spiriva and or Q-bar? I don't believe so. Okay. So why do people get short of breath? Something that I say every single week is that breathing is multifactorial. There are so many different factors that impact how well or how poorly you're breathing. The reason why I believe many people get short of breath after taking these medications, I think it really has a lot to do with technique. And again, I will bring you back to the fact that when you're taking your medications, you don't want to be in a situation where it's high stress. You don't want to be in an emergency. Make sure you're relaxed, okay? Get yourself into the rhythm. Do some nice, easy breathing, in through your nose, out through your mouth, in through your nose, out through your mouth. In the same way that people often hold their breath when going up the stairs, and they say, well, I was able to walk up the stairs and I was fine, but when I got to the top of the staircase, I was short of breath. I think there's a very similar phenomenon that goes on with medications, which is that I think, number one, people get anxious, when they start to take their medications, and so they're not relaxed. They may be starting to get a little short of breath anyway. I also think that people can hyperventilate. I also think that people can hold their breath a little bit too long. So remember that you should be holding your breath for anywhere from a count of 5 at the outside end, 10, and then go back into nice relaxed breathing. Don't go hold your breath and then go right back into the nice controlled breathing technique. So I would say start off with controlled breathing techniques. When you're taking your medication, okay, take a deep breath in. Blow all the air out, okay? Put this in your mouth, squeeze, breathe in, and then go right into a nice controlled breathing technique, and that should take care of that. Another thing, why do I sometimes feel lightheaded when I use my Symbicort or albuterol? Again, Symbicort and albuterol do have mild stimulants in them, but I don't think that they get into the body fast enough to really cause your lightheadedness. I think the biggest culprit in a case like this is going to be either hyperventilation or the breath hold is too long. So again, same type of thing. Okay, none of these drugs should specifically, go into your system and cause a symptom or side effect of shortness of breath and or headache and or lightheadedness. Okay. Any questions, Nicole? Okay, so let's keep going. Is there any way to simplify meds nomenclature for us dummies? And again, I mentioned this slightly before. Believe me, I ask the same question all the time, and I've been thinking about it for years. And like I said, this week, I really spent some time thinking about it, and then it like crystallized in front of me, okay? So one more time, I don't want you to memorize all the names or all the generic names or all the brand names or all the classes. Just think of it like this: A, B, C, okay? A being anticholinergic, B being beta-2 agonist, C being corticosteroid, and just know that the overwhelming majority of patients will take one drug from each class. Know which those are, and that should keep you straight. This is a funny email, I'm just going to say it anyway. So there are bronchodilators, anti-inflammatories, beta-2 agonists, anticholinergic, combos, long-acting and rescues, not to mention a baker's dozen of brand names and generics, and new ones waiting in the wings. On top of this complexity, patients react differently to different meds. This is exactly why proper medication use is so, difficult for patients to understand, and it's even difficult for clinicians to understand. So we're going to be, at some point later this year, hopefully by September 15th, my book will be out, and I'm going to put in some worksheets, and I'm going to make these worksheets available to you even before the book comes out, but a nice simple way for you to know what you're taking, how should you take them along with your schedule. Okay, next question. So the one thing I got from your webinar was the time waiting between the Spiriva and the Advair. None of my doctors had given me that info. I have been on full-time oxygen for 3.5 years. When I first started the Spiriva and Advair, I could only hold my breath for about 10 seconds. I have now built that up to 30 to 35 seconds. My theory being the longer the medicine is in the lungs, the more effective the more effective it is. Your thoughts. My thoughts: let your breath out. Okay? 30 to 35 second breath hold is too long. And let me talk about breath holding as a general rule. Okay? You're right. You are correct in that, there is going to be some disbursement of the medication by a breath hold, but we want a 5 to 10 second breath hold, okay? When you hold your breath, and a phenomenon occurs that is we call it the Valsalva maneuver, okay? And essentially when you're holding your breath, okay, what you're doing is you are essentially locking down air from moving in and out, and that's going to affect the thoracic pressures, and it's going to affect the abdominal pressure. So let me just tell you what happens when you start to hold your breath. I'm holding my breath now. Pressure in the thorax is starting to build up, okay? When you hold your breath, pressure in the abdominal cavity is starting to build up. And when this pressure builds up, it increases the workload on the heart. It can certainly increase the constriction of the vessels, increasing your blood pressure. And if you have something weakened in your thoracic cavity, okay, and particularly people with emphysema wind up with hyperinflated lungs. They have air pockets, that can sometimes be fragile. Okay, so there's something called a pneumothorax. By holding your breath in this way, by creating this Valsalva maneuver, you can actually cause a leak in the lung, or you can cause one of these air pockets to rupture. You can also increase your blood pressure. You can increase the workload on the heart. So breath holding is something that pulmonary patients and cardiovascular patients should almost never do. And, particularly when it comes to exercise, there's a natural tendency when you're pushing or pulling to hold your breath. But again, all the pressures in here are increasing the workload on the cardiovascular system, the pulmonary system, all the pressures in your abdomen are doing. So again, breathing in for 5 to 10 seconds, 30 to 35 seconds, very admirable, okay, but I don't recommend it. You got a question? All right, we have a question from home.
Yes, we have a question from Rita about the specific combinations of drugs that she's using. Rita, would you like to ask your question?
Rita, are you with us?
Rita, say something.
Rita, can you say something? If we can hear you, then you can just go ahead and ask your question. See, I don't hear anything from Rita. Can I just...
Yeah, let's hear, if we have a copy of Rita's question, let's hear the question.
Yes. Questions about medications, and she says that her process is Performis and Qvar in the morning. These are anti-inflammatory. Then she uses Duoneb 4 times a day. She uses Spiriva whenever she leaves the house. She does the Duoneb 4 times during the days, but she also uses Combivent whenever she needs it outside of the home. She's concerned that she might not be taking the right combination to ensure a good breathing day. And she says sometimes her doctor gives her new inhalants and asks her if she likes it, but she feels she doesn't really know have enough knowledge to know the difference.
Okay, so can I just hear that list of medications one more time?
Sure. That is...
So we have Perforomist, we have Combivent,
and Qvar.
we have Qvar. What else do we have? Spiriva,
Yes. Duoneb.
Duoneb. Okay, what else?
Spiriva, Combivent, and I think that's all.
And how many times a day are we using Combivent?
Whenever she needs it.
As needed. How many times a day are we using Duoneb?
4 times.
How many times a day are we using Perforomist? In the morning with Qvar, right?
Yes.
And what about Spiriva?
Whenever she leaves the house.
Okay, use the house. Okay, so people, let me just explain to you now. This is what's crazy about this, okay? Not you, Rita, but you have this list of medications, and Perforomist, Combivent, Duoneb, Qvar, Spiriva, none of those things actually mean anything. It's like saying, you know, Batman, Superman, The Flash, and Aquaman. It's like, unless you know exactly what they are, it's very difficult to know what's going on. So that's where this list comes in, okay? So what I would do if I were you, and the purpose of this list, is for you to say, okay, what on earth am I taking? And let's break this, and you know, Rita gave me some specific drugs that I'm going to address, but for everybody here, you can do this exact same thing. So you should look at your medications and go to that list. So let's start with Perforomist, okay? So Perforomist, I'm going to tell you, is formoterol. And formoterol is a long-acting beta-2 agonist. So that falls under group B, okay? Qvar is a corticosteroid. So that falls under group C. And Spiriva is a long-acting anticholinergic, and that falls under group A. So with Perforomist, Qvar, and Spiriva, we've now covered A, B, and C, all long-acting, okay? Now, you mentioned that you take Perforomist and Qvar in the morning, but Spiriva at some later time. It is a known fact that by taking your beta-2 agonist, which is Perforomist, at the same time or in close proximity to your anticholinergic, the effects are multiplied. And so I would recommend taking your Perforomist first, which I believe is a nebulizer, okay? If it's not, it's okay. You can still take it whether it's a nebulizer or an inhaler, okay? But that's a beta-2 agonist, which is a long-acting bronchodilator. That's going to get the bronchodilation, meaning opening up the lungs, going. Next, take your second bronchodilation, your anticholinergic, which is Spiriva. And then that should clear the way for the corticosteroid, which is Qvar, which I mentioned is the star of the show, right? Because it's the anti-inflammatory medications that are going to have the long-term impact of decreasing inflammation, decreasing swelling in the airways, and allowing you to have long-term good air movement in and out of the lungs. Now you talked about Combivent and Duoneb. So let me tell you this. Combivent and Duoneb are the exact same thing. So both Combivent, which is a metered dose inhaler, and Duoneb, which is a nebulized medication, contain a short-acting A and B. So it contains a short-acting anticholinergic, which is ipratropium bromide or Atrovent, and it contains a short-acting beta-2 agonist, which is albuterol. Okay? So those drugs are meant to fill in, and if you remember, the medications that we talked about before, the long-acting medication should be 12 hours apart at least, and then filling in as you need it with these other medications. But remember that if they contain the same medication, so as an example, if you took Perforomist, which is a B, and Spiriva, which is an A, and then you take Combivent, which is an A and a B, but short-acting, an hour later, then clearly you are not well controlled, and you need some type of greater support than these inhalers are giving to you. And you may need something like a systemic drug, like a steroid, okay? The other thing to keep in mind is that the Combivent and the Duoneb are short-acting. They come on in 5 to 15 minutes, but they should be lasting 4 to 6 hours. And one way to know if you're well controlled or not, or if you're heading towards an exacerbation or not, is if you are finding that you either need more of your rescue drugs, or you need them more frequently, or they're not lasting as long in terms of the relief that you're getting. That is an absolute warning sign that you need to discuss with your doctor with respect to, hey, maybe something is going on here that I need to really address with something more serious than just these inhalers. Do we have another question?
Yes, we have a question from Cindy about IPF versus PLCH, pulmonary Langerhans cell histiocytosis, if I'm saying that correctly.
Okay, I'm going to have to say that even without hearing the question, I have to say I don't know, because I have never heard of PLCH. And I'm sorry about that. I have never seen it in a patient. I have never seen it in a book, but I will look that up. And if you email me, well, what is the question, just out of curiosity?
The question says that she's asking, this information that you're giving, is it also relevant for the PLCH? Because her pulmonologist has diagnosed her with IPF, but she's thinking, could it be this other disease instead? And she said, can you give us any thoughts or information on that? Because she can't seem to find very much on it.
I will look this up. I have never heard of it. So my answer is, I'm sorry, no, but I will look into this. My email is noah, Noah, at pulmonarywellness.com. If you just send me an email reminding me of this question, if I can find any links or information on it, I will certainly link you with that. Okay, other questions. So I have severe COPD and I am on oxygen 24/7. Additionally, I sleep with a CPAP machine. During rest, I'm on 3 liters from my home concentrator. When I'm out, I use 4 liters on my portable concentrator. Even on my home unit. This sounds very familiar. I think this is Becky. We just asked that question before. All right, Becky. That was a good trick, trying to get in 2 questions of the same kind. Just joking. But I'm going to go on to another question. Can you explain in lay terms how these medications work? What do beta-2 agonists and anticholinergics do? Since I do not experience any apparent breathing benefit from them, I need to understand better their purpose to stay motivated to take them as prescribed. So once again, and again, I don't mind explaining it over and over again, because these are confusing topics. And so essentially, medications will break down into 2 main classes: bronchodilators, anti-inflammatories. So 2 main categories, those aren't classes. Anti-inflammatory means it reduces inflammation. And one of the problems with people with lung disease is that inflammation is a huge problem that causes the smooth muscle that lines the airways to become inflamed, thickened, cutting down the amount of air that you're cutting down the amount of space that air has to move in and out, therefore making you more short of breath and increasing the work of breathing. The bronchodilators, broncho means airway, and dilators means to open up. So the bronchodilators are designed to open up your airways. And then the difference between the beta-2 agonist and the anticholinergic is that they are 2 different classes of bronchodilator. Essentially, they're both designed to open the airways, but they do it by hitting different physiologic pathways and different physiologic binding sites. And we have another question from home.
We have a question from David about a nebulizer.
Hey, David. So, can you hear me, David? David, are you with us?
David, I think we can hear you if you want to ask your question directly. But you don't have a mic. We can hear you, though. Can you just give it a try?
Dave, I think you do have a mic. I can hear you. David, please send me $20 for telling you that you have a microphone. What is your question, sir? Okay, so the question is, you have a nebulizer and you're wondering if you could use it with any type of saline solution and or distilled water, and would there be any benefit to it? So the answer is many people do use a nebulizer with saline and or distilled water. The first thing is, of course, ask your doctor, okay, can you nebulize with saline solution? Can you nebulize with distilled water? So what are the benefits to it? Okay, the benefits are that very often people with lung disease, and people in general, but it has a greater impact on people with lung disease, are chronically dehydrated. Okay, one thing that people say, or that's kind of a known fact, is that by the time you're thirsty, you're already dehydrated. So the first thing would be increase your fluid intake in general. I like to recommend people sleep with a cool air humidifier at night because we lose a lot of water overnight. So we lose a lot of moisture from our bodies during sleep. The benefit of using these, what we call wetting solutions or wetting agents, is that by breathing this air in and out with this saline solution, you're actually going to moisten the airways. It can have the potential impact of making them less irritable. If they're dry, they're going to have a harder time moving air in and out, and so it could help with that. But then the other thing is that if secretions are an issue and you're dehydrated, that's going to make your secretions or mucus a lot thicker. And when the mucus is a lot thicker, that makes it much more difficult for you to clear. And if the mucus is difficult to clear and it winds up staying in your system, then that is going to definitely make you more prone to infection. So I do believe there is benefit to it. I want you to check with your doctor to see if he's okay with it before you get going with that. Okay? Okay, so let's go to another question from home.
Let's put David.
What's that?
Dennis on and see if he wants to ask a question.
What's that?
Dennis might want to ask you a question. I'm going to unmute him and see if we can get hold of him. Dennis, are you there?
Dennis? Dennis, are you there? I think Dennis is either watching basketball or hockey, but Dennis, feel free to come back in if you want to. I'm going to go to another question from Kathleen, and the question is, any tips on increasing oxygen saturation while exercising? Would rescue inhaler shortly before help? And what about long-term saturation improvement? Is it possible? So I think I addressed long-term saturation improvement, okay? One thing I forgot to mention before in response to one of the questions is that don't get confused into thinking that the medications you're taking are going to be the remedy for desaturation, because they're not, okay? The desaturation comes in, as a direct result of your lung disease, and it's not like your saturation is going to be 87% and then you're going to take these medications and it's going to move up to 95%. Certainly if it helps you move more air in and out, it can help a little bit. But don't get confused between taking the medications and the mechanical difficulties of moving air in and out, which is an actual physical thing, versus the oxygen saturation, which is a cellular chemistry thing. So any tips on increasing oxygen saturation during exercise? There are a number of things that you can do. And what I'll say, to state the obvious, is you can use oxygen. Using supplemental oxygen is going to increase your saturation during exercise. As I mentioned several times in the past, we use more oxygen here probably than anyone else in the country because I think it's a very valuable training tool. Even if somebody's not on oxygen all the time, by using this and allowing them to achieve greater saturations, this allows them to get a greater workout. And it's not the oxygen that makes the change in the body. It's not the medication that makes the change in the body. It's the workout that is actually going to cause your lungs to be able to move air in and out better. It's the workout that's going to allow your heart to pump blood better. It's the workout that's going to allow your muscles to become more efficient at using oxygen. So I am a firm believer in using supplemental oxygen in even in cases where people aren't on 24/7 oxygen. The other thing, and I'm going to get into this in more detail next month when we talk about exercise, but I'll just give you a little tip. When you first start exercising, so the first, let's say, 0 to, let's say, the first second to, let's say, the first 15 to 20 minutes of exercise are the least efficient. And the reason for that is because your body is not yet warmed up. And from a biochemistry perspective, your body is not the most aerobically efficient. And when we say that your body is aerobically efficient, we're talking about the fact that your body is really efficient at using oxygen right now. The longer your workout goes on, the more efficient the body becomes, because you actually switch over into a different type of oxygen metabolism, and that makes it more efficient. So one thing that we do often with our patients is we try to arrange the actual workout. By that I mean the order in which you do the different exercises to maximize success. And what do I mean by that? Let's say, as an example, we have 3 exercise machines: a treadmill, a bike, and a UBE, which is the upper body ergometer, or the arm bike, some people call it, okay? From the perspective of which is the greatest workload and which is the least workload, from lowest to highest, the lowest workload would be the UBE, or the arm machine. The second would be the bike, and the most vigorous would be the treadmill. So if we take the perspective that your body is the least efficient at the beginning of the workout, I would want to use the lightest workload exercise, which would be the arms. As you start to shift towards a more aerobic metabolism, then maybe you're ready for the bike. As you start to become real efficient, then you might move to the treadmill. Now there's a case we can make for exactly the opposite, and that would be for the person who fatigues easily, or for the person whose legs get tired, in which case it might be to their benefit, to do the treadmill first while they're fresh. But again, when it comes to oxygen saturation, the way that you're going to get the most efficient use over the course of the workout is to start out with the lowest intensity exercise, build up to the highest intensity exercise as the workout goes along and as you become more efficient at using oxygen. Okay, let's go to another question. When I exercise at pulmonary rehab, I sometimes get a headache. I did this today and felt like I could just lay my head down and take a nap. I try to keep my oxygen sats between 92 and 94%. I use 3 to 5 liters depending upon the activity. They checked my sugar today and it was 100, so that's okay. So that would be one thing I would definitely want to check. Headache during exercise, check your blood sugar. I think I'm breathing okay, 2 in, 4 out. My lung function is in the mid 20%, and I do pretty well for my lung function, better than a lot of others I know. This doesn't happen every time. The RT today said we would try me on a mask next time instead of just using my cannula. Okay, here's my thoughts on that. Okay, a headache during exercise, again, can be multifactorial. It can be many different things. If it's not your blood sugar, okay, and if it's not your oxygen saturation, the thing I would want to look at are blood pressures, okay, because sometimes what happens is, especially in people who are less conditioned, just imagine that the hardest time to maintain your blood pressure is when you're standing up, because when you stand up, all the blood rushes to your feet. And the way that blood gets pumped back up to the body is essentially the calf pump, okay? So the heart pumps blood to the body, the calves are responsible for pumping blood back up to the heart and the brain. There are some people who have something called orthostatic or postural hypotension. And what that means is that when they change position, particularly when going from lying down position to sitting position, or from going from sitting position to standing position, it causes their blood pressure to drop. And this is why a lot of people say, when I first sit up in the bed, I have to stand for a little while, or when I first stand up, I have to stand for a little while. When I first sit up in the bed, I have to sit for a little while, or when I first stand up, I have to stand for a little while, because I get either short of breath or lightheaded or dizzy or something like that, okay? So just think about it like this. A possibility is that maybe your calves are not strong enough to return the blood to the upper body in order to meet the demand. So think about it like this. You stand up on the treadmill, your blood pressure drops because the blood, which is a liquid, is naturally going to go with gravity to your lower extremities. Your body is then going to sense this drop in blood pressure, because the body essentially measures blood pressure in the heart and the carotid sinus. So there's a point in the aorta, it's called the aortic arch, and there's a point called the carotid sinus near your carotid artery. that measure pressure. They're called pressure receptors or baroreceptors. Okay, when these receptors pick up the fact that your blood pressure has just dropped 20, 30, 40 points, okay, they're going to signal this as an emergency, and they are going to send out a signal to the body, we need to raise the blood pressure. The way it's going to do that, and I've mentioned this many times in the past, is by enlisting the help of the sympathetic nervous system and popping out a whole bunch of adrenaline. Okay? That adrenaline can sometimes be enough to cause a headache. So what I would suggest, in addition to using the mask, okay, the next time you go to rehab, ask the respiratory therapist to do a couple of different things. The first thing I would like to do is take your blood pressure at rest on both arms. Let's see if there's a difference between right and left arm. For the majority of people, there is not. However, if there is, okay, let's say, for example, your right arm is always 20 millimeters of mercury higher than your left arm. Every time, if I take your blood pressure on the right arm, that means I'm going to get a higher reading, and I may overestimate your blood pressure. If I take your blood pressure on the left arm, I may underestimate your blood pressure. And so as a bare minimum, you have to know who has a difference arm to arm. So the technique I would use, I would say first take a right and left blood pressure sitting in a chair at rest. Record the numbers. Next, keep the blood pressure cuff on you and stand up, okay? And let the therapist be next to you when you do this. And it would be great if you also had an EKG monitor on you as well to see if there's any potential arrhythmias there. But after you've been standing for 10 seconds, let's see if your blood pressure drops, okay? And if that's the case, then that would be a positive, sign of orthostatic hypotension. And then with that, there are certain things that you can do to improve that situation, okay? I would encourage you to do this maneuver, contact me after it gets done, let me know the results, and then we could talk about things that you can or can't do. Okay, we have another question from home. Who's it from, Nicole?
We have a question from Karen. It's related to exercise.
Okay, Karen. Karen, can you hear me? I can. Yes, I can. Okay, Karen, let's hear your question. Okay, so again, next month is exercise, so that's going to be huge, 1.5 hours to 2 hours on exercise only, but I will address a couple of things here. So I think there was a tiny bit of misunderstanding about what I said related to upper body motion, okay, and consumption of oxygen and how and why different things work. So let me just clarify that for a second. The reason why upper body activity is difficult for pulmonary patients or people with any type of respiratory difficulty is as follows, okay? It doesn't have to do so much with the amount of oxygen consumption, because you certainly would use more oxygen walking on a treadmill than using, let's say, the UBE, the upper body ergometer. However, when you put your arms out like this and when you do these overhead type activities, okay, it puts the respiratory muscles at a poor mechanical advantage, and therefore it increases the work of breathing and makes it more difficult for you to move air in and out. So let's start with that fact. So any activity where you're using your arms in an unsupported position will put the respiratory muscles at a poor mechanical advantage. What I said was not specifically keeping your arms close to your body, but what I said specifically was fixing the arms, okay? And what I mean by that is leaning on something. And leaning on something can either be leaning on your knees, leaning on a table, leaning on a chair, putting your elbows on your knees as you lean forward, okay? And I talked about the concept between open chain versus closed chain activities. So the open chain activity, meaning that my hands are free and doing these overhead activities, but when you fix the arms in any of the ways that I just mentioned, okay, what you're actually doing is you're taking the muscles of your chest, your back, your shoulders, the muscles that do things like this when they're in an open chain, right? But when we fix the upper body, they actually work in their reverse activity to help elevate the rib cage and actually assist the respiratory muscles. So that is my point with that, and that too will be in the book. Okay, the other thing, and I think Nicole mentioned this, but I'll mention it again, is that within the next week or so, we will have archived copies of these webinars on our website for you to view. Now let's talk about statins for a little bit. Okay, so statins, statins essentially are cholesterol lowering medications, and they're designed specifically to lower the LDL or the bad cholesterol. One of the side effects in some people, and in some people it can be quite severe, is muscle weakness and, or as you described, muscle wasting. And it sounds like you've been on statins for quite a while, and that gives you quite a bit of time for your muscles to atrophy, which means get smaller and get weaker. So it's good that you're off the statin. Okay, that should help a little bit. But any activity that you're going to do with your arms, I would certainly suggest a combination of aerobic activity, meaning sustained rhythmic activity, things like the UBE. Here at the Pulmonary Wellness and Rehabilitation Center, we use a program called Armorcise, which I will introduce to you next month, and I will supply a copy of it to you that you can do on your own with your doctor's blessing, and also strength training with weights. And again, in the arms, if you think about what exercises are best, essentially, if we think about the upper extremity, we have the shoulder muscles, we have the biceps over here, we have the triceps, and we have the forearm muscles. You want to do a well-rounded protocol that it hits all the muscle groups and addresses it from a muscular endurance point of view, which is the aerobic activity, and you also want to address it from a strength training point of view. And we'll talk much more about that next month during exercise session. Next question.
We have a short question from Tom. Tom might want to be able to, Tom, are you able to ask your question for us?
What is it called? Are you saying salt? Did you say a salt room? I have not heard of this. Can you tell me a little more about it? Have you used this before? It does. Okay. It helps loosen the mucus? Okay, let me ask you a question. Is the room warm or cold? Regular room temperature. And is it moist or dry? It's dry. I've never heard of it, and in my mind I'm not really sure why that works or doesn't work. How did you get recommended to that? Uh-huh. Uh-huh. And you go someplace to go in this salt room? Where would you go for that? Like a spa? Okay. I have not heard of it. I don't know anything about it. I will look it up, and feel free to email me and I will let you know my thoughts. More? We have another question from home.
Yes, we do. We have another question from Rita about this same topic.
The salt room?
She asks, have you ever heard of salt inhalers?
Okay, so no, I have not heard of salt inhalers aside from smelling salts that you give to somebody when they pass out. Now, saline, okay, is a salt water solution. It's an isotonic salt water solution that mimics the body's saline. So I'm not sure if that's what we're talking about, okay? I personally, I wouldn't recommend you going to the deli and pouring out some salt in your hand and inhaling it. I can't imagine that that's going to work out very well for you. But again, I have not heard of it. Clearly others have, because that's the second question in a row. I will look it up and I will address it. Thank you for your question.
We have a question from Kim about O2 sat levels.
Okay, Kim, are you with us?
Kim, would you like to ask your question directly?
Kim?
Can say something.
Okay, I don't.
Okay, so do we have Kim's question, Nicole?
We do, I can read that. Kim says her mom has scleroderma, PF, PH, and severe Raynaud's. At rehab, they're unable to get an O2 sat due to the Raynaud's. So at first they tried to milk her fingers, now they just tell her that they can tell by looking at her that her O2 sat is okay. And Kim is saying that she's concerned, she says they are well trained and they say that because they also do EKG on pulmonary rehab patients, that they're already doing more than is required. She wants to know, can you tell someone's O2 sat by looking at their color and heart rate, is that satisfactory?
Okay, without commenting on another program, that would never happen in my program. So the way to kind of ask yourself this question is, if you were going to fly a plane and you didn't know what altitude you were at, and you didn't know north, south, east versus west, is it still okay to fly the plane? To me, I don't like surprises. And pulmonary rehab is not a specifically dangerous activity, but it's got its moments. And done wrong, okay, done right, it's relatively safe. But that being said, even if you do everything right, if you get the wrong person on the wrong day, something can go wrong. Done wrong, you can create the wrong person, even if it wasn't the wrong person, on the right day, okay? So there are a couple of comments about that. Can I tell your oxygen saturation by looking at you? If you are a magician, a fortune teller, a mind reader, a body reader, a specific oxygen saturation meter, then maybe. If you have some kind of magical powers, then it's possible. However, my question would be, if I could tell your oxygen saturation just by looking at you, why would I need a pulse oximeter? Now, sarcasm aside, but the reason why I say it that way is because I hear so many things about what's required. Okay, what is required? There are many pulmonary programs that run their programs without EKGs or telemetry. They run their programs, without taking blood pressures every 5 minutes, or they do it without, I'm not looking to do the bare minimum. I'm looking to do the absolute maximum to keep my patients safe. Safety is my number one priority, okay? So I need to know what is happening in my patient's body. That means I want to see their EKG the whole time, okay? And a lot of people believe that you don't need an EKG on a pulmonary patient because they're a pulmonary patient, they're not a cardiac patient. That's all well and good as long as the patient is fine, okay? And I always say the patient is only as safe as their last exercise session. Just like a flight, a plane is only as safe as its last flight. It could have 999 safe flights, and then if you have a flight that's not safe, it kind of undoes the rest of them. Same thing. So I don't want to assume that just because I've known you for 5 years, that just because everything was okay for the first 5 years, that everything's going to be okay in your next workout. So in our program, we have you on constant EKG monitoring. So you're on telemetry. We always have an accurate picture of your EKG, of your heart rate and rhythm by EKG. We're checking your blood pressure in 5-minute increments. Why? Because blood pressure changes very frequently. And we also monitor your saturation in 5-minute increments, okay? So again, these things can change. Now, scleroderma, Raynaud's, okay, these are all connective tissue diseases that are absolutely challenging when it comes to getting an accurate oxygen saturation. Again, for somebody to say, I can tell your oxygen saturation by looking at you. That's like the great Kreskin, or like somebody at the carnival saying, let me guess your weight. It's like, let me guess your oxygen saturation or you win a prize. You cannot, okay? Now, if you are blue or gray or black, not African American or pigmented skin, but black, I can assume that your oxygen saturation is probably not that good. However, aside from that, I don't want to make any assumptions, okay? Here are some suggestions. Number one, hand warmers, okay? I could use the basic old-fashioned hand warmer, which is a glove, wear gloves, but also they have these self-heating hand warmers that as soon as you take them out of the package, they will heat up, and that can often allow you to get a much more accurate saturation by bringing greater blood flow to the fingers. The other thing is that there are some pulse oximeters. We have the single most accurate pulse oximeters on the market, and they work on a totally different technology, and they're designed specifically for people who have a hard time getting oxygen saturations, or for neonates, okay? So you can ask your program if they would consider getting one of those. And then the final thing is that because scleroderma and Raynaud's usually affects the extremities more than central, you can ask them to get a forehead adapter, okay, to put onto their pulse oximeter, and then it takes away any complications from the Raynaud's or scleroderma. And that just goes right on your forehead, and it gets a very clean heart rate and oxygen saturation reading. And just one other comment, when a program says we're doing more than is required, again, that really kind of bothers me, because it's like, again, I'm not looking to do the bare minimum. It's like, don't forget, a lot of programs, we all work under insurance guidelines to some extent, and we work under Medicare guidelines to some extent. And, if Medicare says to me, you only have to take one blood pressure during a session, but I know that's not the right thing to do. I'm not going to say, well, Medicare doesn't require me to take a more frequent blood pressure. I'm going to do what's best for my patients in each and every session to make sure that they're safe and to make sure that they're getting the maximum benefit from the program. So, the requirements are not, here's one thing. In New York City, we have these grades on the restaurants for cleanliness. Let me tell you something. Look them up and see what you can get away with and still get an A. So minimum requirements are not what we base our program on, and I would really encourage them. I need to know your oxygen saturation, plain and simple. Otherwise, I have no way to know if you need oxygen, how much oxygen do you need. So again, hand warmers, forehead sensor for pulse oximetry. One more question?
There's one last question that came up a couple of times.
Okay.
About the chart of medications, and if people could get that. And we did have a link to that.
Yes.
So we can send that out again, right?
Yes, we will. What I'm going to do is I'm going to modify the chart, and we will resend. We'll send it out today as it was, okay? But actually, you don't have. You can modify it yourself. It's a very simple modification. Now, is that looking forward or backwards to you? Okay. So very simple. Okay. This chart is accurate, and this really ingenious way that I thought of, okay, after going to the mountain and meditating on this for many, many hours, is a simple ABC formula. And the only thing I would do is I would reverse A and B. And remember that A is anticholinergic, so put a A over here, put a B over here for beta-2 agonist, put a C over here for corticosteroid, and cortico just means that it's cortisone-based. And just remember that the majority of people take a combination of A, B, and C, and understand the differences between the short-acting and the long-acting. All right, I have just two more questions from emails, okay? This is from a pulmonary disease icon, Vladi Rosenbaum, and he says, Noah, it might be helpful if you say a few words about taking care of inspiratory muscles, which weaken over time and create a problem with inhalers, especially DPIs, which are dry powdered inhalers, and are taken with oxygen conservers, which may not be triggered properly to release a bolus of oxygen. So, absolutely, inspiratory muscle training is very important, okay? All muscles weaken over time if they're not stimulated. So as we age, most of our strengths are somewhere between the age of 20 and 30, and then we start losing ground unless we really make a big effort to keep this muscle strength. So when we talk about inspiratory muscles specifically, the main muscle of inspiration is the diaphragm. We've said this over and over again. And so some things you could do to strengthen them: diaphragmatic breathing. There are also specific inspiratory muscle trainers, things like the P-Flex and other things. But let me make one thing clear. A lot of times people come to me and they have these different devices, whether it be the P-Flex or the acapella valve, which can also be used as a muscle trainer, or the incentive spirometer, which is what people get in the hospital, where you try to raise the balls up by breathing in. All of these things are well and good if you're not that active. But when you partake in a vigorous exercise program, this serves the benefit of training the inspiratory muscles, the expiratory muscles. It also helps to improve the mechanics of inspiration and expiration. And so absolutely, one thing also is that Vladdy talks about the fact that when you have weak inspiratory muscles, you have a difficult time taking the inhalers, particularly the powder inhalers. Agreed 100%. And so there's a huge benefit in strengthening those muscles. One thing I'll say about the powder inhalers that are a little different than the straight shot, meter dose inhalers with the aerosol, is that with the powder inhaler, if you don't get the whole thing the whole time, the powder is still in there. So there's actually nothing stopping you from going through the whole procedure again. Now, don't re-click the unit so that you get a second dose of the medication, but once you open it up and that powdered medication is sitting in that chamber, you can actually breathe in, blow out, put it in your mouth, and take a second one to begin with. The other thing that Vladdy mentions is the fact that some people may have a difficult time triggering their oxygen conservers. So when we talk about oxygen conservers, a lot of what happens is the conservers are designed to only give you a burst of oxygen when you inhale through your nose. And it should be very easy for people to actually trigger the device, but what's actually a big problem with this is that a lot of people think that they take the breath in through their nose, they hear the device trigger, and they assume that they're getting the maximum benefit of that oxygen. But all that's doing is putting that oxygen right there in your nose. And so what's really important is that every time you trigger that oxygen, that you take a deep breath in through your nose so that it's actually brought into the lungs where your body can use it. Because remember, we talked about the fact that when the air is in your windpipe, it has no way of getting into the bloodstream. So with the conservers, real important, trigger the device, but also take a deep enough breath so that the oxygen actually gets into your lungs where you can use it. Okay, one more question. And this is two questions that I'm going to combine into one. So one is, my question for tonight is, what are the symptoms for not taking Symbicort 12 hours apart? In the last 2 months, I have messed up my timing a lot. It started with sleep changes. I would miss a dose, take it maybe 4 hours late, and then take the second dose at usual time. So that means you're now taking it, your first dose was taken 16 hours after the last dose, and then the next dose was taken 8 hours after that dose. And here's another question that says, I recently started Spiriva and take it within an hour of the same time every morning. However, there will be times that I have to take it earlier or later. How important is the timing on effects of the medication? I'm going to say very important, and let me give you an analogy, If you know that your car goes 200 miles on one tank of gas, then you can pretty much bet that every 180 miles or so, you are going to, you're going to be pulling over and refilling your tank. So that's all well and good as long as you do it less than that. But if you were to, let's say, go 220 miles, you're going to be pulling over somewhere around the 200-mile mark, not because you're ready to fill up your tank, but because you've run out of gas. Same type of thing with these medications. So the medications are designed to work in 12-hour increments. They're supposed to be taken 12 hours apart in order to give you the maximum benefit. But not so much with Spiriva, but particularly, with Symbicort, which contains a long-acting beta-2 agonist. And I've mentioned in the past that beta-2 agonists can be a stimulant, So you talk about sleep problems. Now you're taking a drug that's supposed to be 12 hours apart, only 8 hours apart. So it's like if you usually take your coffee at 8 a.m. and 6 p.m., but now you've taken it, at 2 p.m., guess what? You're going to feel a lot more stimulated for the next couple of hours than if you were on your regular schedule. Same thing with the Symbicort, and it's not so much of how do you feel stimulated, but having that extra sympathetic nervous system stimulation can actually cause complications like vasoconstriction, meaning that your blood vessels constrict, your blood pressure can go up, your heart rate can go up. If you are prone to arrhythmias, or even if you're not prone to arrhythmias, it can trigger or increase the likelihood of an arrhythmia. All right, and I think that wraps us up for tonight. Thank you all for coming. As Nicole mentioned, the next webinar will be on April 23rd, and that will be at 6 p.m. Eastern Standard Time, and that will be on my favorite subject, exercise and pulmonary disease. And last but not least, I will mention again, these are not my recommendations to you. These are not a replacement for medical advice or recommendations or prescriptions from your doctor. These are my thoughts, opinions, and observations that I've observed over the last 22 years by working with pulmonary patients. I'm trying to give you as much information as cleanly as possible. Don't say Noah told me to do it. Have a good evening. Thank you.